There we go. Okay, good afternoon, and welcome to the NNE CTR Research Echo. And it's my pleasure to introduce my colleague Melanie Locker as our presenter today. Melanie will be talking about consenting vulnerable populations. She's been with UVM for almost 25 years and has served as the director of the UVM IRB for the past 4 years. Past roles that she's performed include things as the assistant director for the UVM IRB, and prior to that, as a research analyst in California. Melanie earned her Bachelor of Science in Psychobiology at Quinnipiac University in Connecticut and is a certified IRB professional. And for those who are not familiar with SIP certifications, it's a formal recognition of an IRB professional's broad knowledge of IRB functions and expertise about human research protections programs. So really good reason to have her be our speaker today when we're talking about vulnerable populations. And SIP certification is through the PRIMER, the Public Responsibility in Medicine and Research Organization. So Melanie and all, welcome to the Clinical Research Echo, and thank you, Melanie, for presenting for us today. And I will hand this over to you.
Thank you. I'm gonna share my screen. How's that look?
That looks good.
Okay.
I'm not sure if you're at your starting slide, but yes.
Yeah.
Okay.
Yeah. So the aims of today's presentation for consenting vulnerable populations, I think we want to talk about identifying who the federal regulations call out as vulnerable populations in research, right? So who are the populations in research we need to focus on? We want to understand the regs and requirements when consenting these populations, learn how to mitigate the risks of coercion and undue influence in the protocol, and is there any way we can create tailored informed consent documents and protocols to ensure that we obtain a legally effective consent process? I think that's what we want to focus on today. So a vulnerable participant is any individual who lacks the ability to fully consent to participate in a research study. So more formally, they may have insufficient power, intelligence, education, resources, strength, or other needed attributes to protect their own interests. So federal regulations require IRBs to vote to approve or disapprove research based on the criteria for approval under 45 CFR 4611. And when some or all of the subjects are likely to be vulnerable to coercion or undue influence, such as children, prisoners, individuals with impaired decision-making capacity, or economically or educationally disadvantaged persons, additional safeguards must be included in the study to protect the rights and welfare of these subjects. So IRBs will review the protocol and consent documents to ensure added protections have been described if a vulnerable population is part of the targeted population for enrollment. So as a director of the IRB, this is something that we always look for during committee discussion. Are there vulnerable populations, and have we added protections? So have we identified them in the protocol, and is there added protections for them? And then how do we protect them? Generally in the consent for a process. So the regulations are simply there as a reminder that not all research participants have the ability to consent equally, and it's the job of the PI and the IRB committee and committee members to consider inclusion for potential participants, especially when the aims of the research may be to benefit a diverse population. So we want to we don't want to discourage research with vulnerable populations. We don't want to say, oh, this is hard, we have to do extra things. But we just want to state that we just want to make sure that we design the study to not exclude these populations. So NIH is really specific that the study should not be designed to exclude these populations unless there's a scientific or ethical reason not to include them. So just because we have to do more work as a researcher or in your protocol doesn't mean that we should exclude these populations. So the federal regulations, they call it 3 specific populations as vulnerable. So prisoners, children, and neonates, fetuses of pregnant women. So not the pregnant women, but the neonates and fetuses. They all have dedicated sections carved out in the regulations for these specific groups. So this is what we refer to as subparts B, C, and D. Additionally, individuals with impaired decision-making capacity, economically or educationally disadvantaged, individuals may also require additional protections when consenting. There's not a specific subpart for these other groups, but we are asked to consider their ability to give fully informed consent during the IRB review. So the feds call out specifically the prisoner children's and neonates and fetuses, and then any other groups they mention, but they don't have hard and fast rules and regulations tied to them. So the first part is subpart B, and this is in the regs, and this is the additional protections for pregnant women, human fetuses, neonates. So while pregnant women are no longer classified as a vulnerable population under the revised 2018 Common Rule, specific consent protections still apply to them in research due to the involvement of the fetus. So if a participant becomes pregnant during a study, the protocol and consent document should outline the next steps, which may include a discussion with the investigator and a special consent form for continued participation that covers the risks to the woman, fetus, and offspring. So pregnant women were previously considered a vulnerable population because the fetus couldn't consent for themselves. So, but in 2018, the federal regulations were revised as they wrongly implied that pregnant women themselves were inherently compromised, or that pregnancy inherently compromised a woman's decision-making ability. So now it's not that you're a pregnant woman and you can't make a decision, it's that where the regulations are protecting the neonates or the fetuses since they cannot consent for themselves. So the shift in classification emphasizes a woman's autonomy and capacity to make her own decisions about participating in the research while still maintaining necessary protections for the fetus through specific research criteria and consent requirements. So the IRB has to fulfill a number of special regulations that the protocol goes through, which in itself is another 40 slides. But in terms of consenting the women now to participate, that's no longer considered a vulnerable population. So informed consent must now include the risk to both the women and the fetus, and the research can only proceed if the risk is minimal and the knowledge gain cannot be obtained otherwise, or if the research has the prospect of direct benefit to the women or both the women and the fetus. So we have to make sure that when the protocol is presented to the IRB, that those aims and the risk-benefit ratio is going to make sure that the benefit is minimal risk and that there would be not greater risk to the woman or fetus. The consent also needs to be obtained from the father with specific exceptions for situations like rape or incest, and there may require ongoing consent documentation. We at UVM don't see a lot of protocols with research around neonates or fetuses here. I don't know in Maine if you guys do have that, but we don't see a lot here. Subpart C, on the other hand, is additional protections for prisoners, and we do a lot of prisoner research here at UVM. So prisoners, because of their incarceration, may be under constraints that could affect their ability to make a truly voluntary and uncoerced decision, whether to participate as a subject in research. So in 1976, the U.S. National Commission for the Protection of Human Subjects issued a report on the issues involved with performing experiments on prisoners. Subpart C of the regulations was developed as a result of the exploitation of prisoners to test drugs and medical devices. It was actually estimated that until the early 1970s, almost 90% of all new pharmaceutical drugs were first tested on prisoner populations. And so that's all the drugs in America, 90% of which they cannot fully give full consent. So when the articles started coming out in the papers and the journal, this was definitely a journalist-driven investigation. That's when the feds came out and said, we're adding to the protection of research subjects and added subpart C. So that happened in 1978. HHS issued regulations addressing prisoners as a vulnerable research population and created this whole subpart C. And they added, not only did they add subpart C for a vulnerable population, but they added restrictions about what can and cannot happen with prisoners in research. So the abilities So they recognize the ability of prisoners to exercise free choice is limited because their autonomy is restricted. By definition, they don't get free choice. They can't walk around, they can't walk out, they don't get to have autonomy. Confidentiality of their participation is difficult to maintain due to the limited privacy of prison spaces. And inducements offered by researchers to prisoners may create undue influence. And that's what happened back in the early 70s is if the prisoners participated in those pharmaceutical drugs, they would get time off their prison sentence, or they would actually get money that they could use in the commissionary so they could that they could actually purchase things. And as you can tell, if you did a violent crime and you got 10 years off your crime, some people were very upset about that. If you were, looking at a new rash treatment. And so prisoners at that time, they represented a population of convenience for researchers, but it didn't mean that they were giving full consent. So they may not reap the benefits from the research participation due to the limits of their incarceration, and they also run a good representation of the population at large. So the subpart C has been around for almost 50 years. We at UVM, we have usually anywhere between 1 and 2 protocols that happen in our prisons here in Vermont. And again, we have to have requirements around minimal risk and autonomy. We do a lot of research where we have the prisoners put their consent forms or surveys or information in signed sealed envelopes. So we try to maintain their confidentiality that way. These are all behavioral. They go through our behavioral IRB. And so we actually look at this quite a bit here, and we've gotten better over the years. And some of our researchers do think this is an easy population for me to go to. But once they actually dig into the regulations, they find it's actually quite hard to do research with this population. So we do a lot of waivers of documentation. So we say that you don't have to, sometimes by signing the consent form and putting your name, that actually puts you at risk for a loss of confidentiality. So since the study has to be minimal risk based off of the regs, we can do a waiver of documentation where someone doesn't have to sign. We do anonymous surveys in sealed envelopes, information sheets in lieu of a fully executed consent form. We don't have a lot of private conversations that we can actually conduct in a prison setting. And a lot of our protocols are conducted in big group discussions, focus groups. Subpart D is the additional protection of children research. So here at UVM, our IRB routinely reviews protocols enrolling children, and we apply subpart D to any protocol enrolling a child under age 18, and our IRB generally requires a separate assent form for children ages 11 to 17. So subpart D establishes the risk-benefit categories for research involving children. So again, they cannot consent for themselves as they are a minor. They need to have someone consent on behalf of them. They can consent in conjunction with a parent, but if you are under 18, the feds recognize that they need to have some other type of consenting for them. So there are only 3 categories that may be approved by the IRB. So I'm going to go over the first 3 different types of categories because they all involve different consenting processes with children. The 4th category requires the approval of the Secretary of the Department of Health and Human Services. UVM has never had been presented with this type of research. I'm not sure if Maine has. It's really, really high risk stuff. So this is our most common vulnerable population that we do here at UVM. And one of the most common is pediatric risk level 1. So this is research with children in which the IRB finds that no greater than minimal risk to the children is presented. And the IRB finds that adequate provisions are made for soliciting the assent of the child and the permission of one parent or guardian. So in this minimal risk example, the regulations allow for the child to assent, and participation is not required regardless of both parents consenting. Both the assent and consent of the parent would be required. Oops, I think this was the wrong one. So for this example, So here's an example of a pediatric risk level 1. So a PI will collect information about the child's medical history from EPIC, from our medical records. They'll measure height and weight and ask the child to complete a couple questionnaires. The participants will need to download an app on their phone to answer the quality of life questionnaires, and the risks are all really minimal. Survey questions, there's a time commitment and a potential breach of confidentiality. So in this type of study that we have here, so these are kids who have cystic fibrosis and quality of life. So you're asking the kids to fill out surveys and give their time. And there could always be a breach of confidentiality with any sort of like software. But we only require one parental signature. So a parent must also consent on behalf to have their child participate in the study. And then our IRB would generally, for this type of study, always ask that a separate assent form also be created for children that are ages 11 to 17. So we would want the child to assent and sign, and we want one parent to sign. So this is what we would consider risk level 1. Risk level 2 is a study that was greater than minimal risk with a prospect for direct benefit. So that's different. The last study had no benefit. We were just collecting data. And this one, we have direct benefit. So research in which the IRB finds that there is direct benefit to the child. So the risk is justified by the anticipated benefit to the subject. And in relation of the anticipated benefit to the risk is at least favorable to the subjects as presented by available alternative approaches. So in this case, we would always want a parent to sign and the child, but we don't require the child to sign. Okay, there's a potential for benefit. And if you're a child, you may not understand what that benefit is if it's a therapeutic. So here's an example of the study we have here. So this is a study for lung infection and cystic fibrosis patients with a new drug. So we're trying to learn about the new vancomycin study drug compared with placebo, and for the cystic fibrosis lung infections. And the children will receive either the new drug or the placebo, and they'll take their inhaler twice a day for 24 weeks. They'll additionally have blood draws and tissue collection, physical exams, and procedures, such as minimal spirometry and electrocardiograms. So in this example, the regulations have identified the child may not be able to make a medical decision in their best interest, right? So due to the complexities of the cystic fibrosis disease. So therefore, assent is not required by the regs, but it is encouraged. So we would say, if they are 17, if they are 16 or 15, anywhere between 11 and 17, we do want to present to them an assent form that would tell them about the study. And one parent must consent. With that being said, the parent can still consent for the child, and the child can still undergo the study in this case, right? So there is a potential benefit and there's a therapeutic benefit. So we would still have that. Pediatric risk level 3 is a little bit, we don't see it as much. So this is a greater than minimal risk study without the prospect for direct benefit. So in this case, if the research activity or component, any component of the research is purely for research purposes and is not for the participants' direct benefit, the IRB can approve the research if the risks are not more than a minor increase over minimal risk. So since the meaning of the definition of minimal risk is controversial, the definition, it has to be minor. And this is where the IRB sort of makes their decision. And this is where they have their conversation about if it is more than a minimal risk, if it's a little more, this is the big conversations at the IRB about what this means per protocol. And it's different for every type of intervention. So the intervention also has to likely have generalizable knowledge about the participant's disorder or condition or other children in the future. So they could say, we're going to do a procedure on a child. It won't benefit them directly, but it may benefit the population at large in the future. It may teach us something in the future that we may be able to use to protect other patients. In this case, the federal regulations require permission of both parents and assent of the child before they can be enrolled. So they're saying, in this case, if there's no potential benefit for the child, then we want both parents to sign on. We want both parents to sign the consent form, and we need signatures from both. So this is an example of a study we had here. The study included 40 children, ages 13 to 18 years old. So 20 were normal weight and 20 were healthy weight. There was 2 testing sessions, including body composition, psychological measures, treadmill exercises, nutrition, and physical activity questionnaires. There was a DEXA x-ray scans in order to do the percentage of fat and lean body and bone mineral density in the participants. And the DEXA scan has radiation. So the DEXA scan isn't there to measure for a treatment purpose for them or to have them for a treatment plan. It was simply there as non-benefit for the participant, but it was giving them radiation. If they did not participate in the study, they would not be exposed to this extra radiation. So in this case, the IRB said, this is a pediatric risk level 3, and it requires the consent of both parents. There's also a monetary incentive since there was so much time involved in the study, and the child would have a hard time understanding the risk-benefit ratio of the research. So here's that coercion for if you're underage, where you may feel like the extra money would be an inducement to sign on. So again, they want to make sure that the parents, both parents, understand before the child assents, because they don't want there to be coercion with the extra benefit of the money. I think, Kim, we're going to do a poll.
Yeah, Mel, just before I click on the polls,
Sure.
there was a question in the chat and it's
Okay.
asking about the first block in the slide. It was, what's the difference between normal weight and healthy weight?
Oh, in the protocol?
Yeah.
I don't remember what the criteria, the eligibility criteria was for normal weight versus healthy weight in this study.
Okay. So as Melanie mentioned, we're going to do something a little bit different as part of the ECHO today. We're going to be using polling. So I'm going to launch the first poll question, and participants are asked to actively engage by answering the poll question, and then we'll share the results of that. So here's the first polling question.
So in this question, you can read this. So we're looking for what out of the 3 pediatric risk levels we just did, 1, 2, and 3. So what pediatric risk level and how many parental signatures would be required for the example below? So the example below is a real study we have at UVM where children with bilateral Wilms tumors account for 5 to 7% of all patients. And certain patients with syndromes associated with the development have been identified at an increased risk for bilateral tumors. So due to an increased risk for renal failure, patients with bilateral disease at presentation are treated with chemotherapy in order to preserve renal parenchyma. Recent evidence suggests that survival of these patients is inferior to similar patients with unilateral tumor. So this study is designed to improve the survival of these children while continuing the emphasis on preserving renal function. So do we think this one's a pediatric risk level 1, where it's minor risk? Or in 1 parent signature is required? Is it pediatric risk level 2, where there's a potential for benefit and we need 1 parent signature? Or is it pediatric risk level 3, where there's no potential benefit for the child and we would require both parents to sign?
We'll just give people a couple seconds to respond, and then we'll share results. I have 8 responses so far.
It looks like we're right. Yes. So in this case, it is pediatric risk level 2. So there's a potential for benefit for this to preserve the other kidney.
I also want to, before we go, I don't know if people have questions about that, but I know that you had your hand up too.
Yeah, I had a question about the subpart B, the pregnant women piece, and I wasn't sure if I should ask it now or if we're gonna loop around to that a little bit later. I can wait too.
You can ask now. It's fine. Yeah.
So my question was, a lot of studies that we have are not about the pregnancy or the neonate, but they include women who may become pregnant. So if they become pregnant during the study, can you talk a little bit about that? I mean, do we need to have a subpart B in all studies that include women who may become pregnant?
Yeah, so you can apply it afterwards, right? So you can apply it afterwards. So usually the regulations are what is your targeted population, right? So if they are your targeted population at the beginning, you would apply those regulations. And I think this is true for all of the studies, is if someone becomes incarcerated later on in the study, if they become pregnant later on in the study, you're not going to become a child, but let's say you have a child and that child is now part of the study later on, right? Because now they've received drug inadvertently through the mother or something. Then you can apply those regulations after the study. And sometimes that require, and sometimes at least depending on the protocol and the risk level and what's happening. At least for the prisoners, you would have to go back into the IRB, do a full committee amendment to say, to meet the criteria for the prisoners, just like you would with the women. Can they still enroll? Do we need to reconsent them? Do we need to pull them off? A lot of our drug studies come from the sponsor with a pregnant partner consent forms, meaning if they get pregnant or their partner gets pregnant while they're in the study, they will ask to consent them to collect data around them or collect data around the child later on. But again, sometimes it's a lot of work to do it up front without knowing that they're not going to get pregnant, like you're saying, and then they get pregnant. So we try to encourage them to say, if you become pregnant or your partner becomes pregnant, sometimes it's easier to submit an amendment after to deal with that. And then we can look at the protocol for that particular patient and the risk and see what we need to apply. So, it's really protocol dependent though. Because sometimes it doesn't, if it's a minimal risk study, it's a survey. It doesn't matter if you get pregnant, right? It kind of depends what the intervention is.
Mel, I had a question. You talked about in the children's populations, age of ascent, and can you talk a little bit about the state variations potentially around age of ascent? And
yeah, I think I want to say so a child is under 18 in all 50 states. In order to assent, that is really it's not even state specific. I think it's institution or hospital specific. So here at UVM, we as an IRB, as an institution, has required assent of children 11 to 17. If you go to UCLA, they require assent for age 6 to 17. We had a study maybe a year ago where they wanted us to assent 3-year-olds. Our committee was like, no. So, and it was a drug study. It was like a randomized placebo-controlled drug study. So like that's not going to happen. So, but we did a project here at UVM probably about a year ago, Kim, where we looked at we revised our assent forms and looked at the ages around the country. We looked at like Harvard and Michigan and Stanford and Indiana and Duke, and they widely vary. There was no like commonality among like what children should be assented at which age. They all say you must assent if applicable, but they vary widely. And so then we also looked at just the pediatric hospitals, right? So the UCL pediatric, we looked at CHOP in Philadelphia, we looked at Boston Children's, and as an institution that was dealing primarily with children, their assenting age requirements were much lower than 11. So they were the ones that were more like 7, 8 years old to 17. And they were requiring, but they also had a lot more money where they had assent forms that were color coded and that they were sort of like graphic novels, like where you know what I mean? They were able to put money into them and make the assent form speak to a child of that age. So we would absolutely do that here, but I don't think we have access to the same, graphic novel details that other institutions do. But that here at UV, I'm not sure what means as if anyone, what's the assenting age requirements for your institution? Anyone? No, or you don't have a requirement. It's maybe per protocol.
And then on that same theme, there are a couple of questions in the chat, which I'll get to in a second, but and then sort of the reciprocal part of that is when a child becomes an adult, the
Mhm.
reconsenting requirements piece?
Yeah, so we also, and again, this isn't for every study, but we also have what's called the age of majority. So we have a consent form that says you were enrolled as a child under 18, and your parent consented on your behalf for you to be in this study. You're now 18, you have autonomy, right? So now you are no longer considered a vulnerable population. You have autonomy to make your own decision. Do you want to continue? And so at that point, we will require the PIs to go back to the participants, say, do you want to? And I've seen a lot of them where the kids say, no, no more. I don't want to come in once a month and fill out a quality of life survey about the cancer I had when I was 6. I don't want to talk about it anymore. And they say no. And that's fine. That's the whole point, right? That is, now they have the autonomy to do that. Now they have the ability to do that. And obviously there's a discussion, but that we do that. So we do have a template for age of majority. And I think that's a valid thing to do, where you are no longer under that subpart B, or for kids subpart D. And now there's now the regs, the feds say, we recognize you as being a fully autonomous person able to consent for yourself.
Thanks. And one of the questions in the chat talks about, does readability of the assent need to be age tailored?
Yeah, obviously it should be between, something that is, with that being said, our regular consent forms for adults who have, not any vulnerable population or problems at all, they should be tailored to ages grades 6 to 8, right? That is what the feds say you should aim for. It's really, really, really hard to do. We have instructions on our and guidance in our consent templates that show you how to use Word, so you can do the reading level in Word and figure out what the reading level is. And I say this all the time: if you take our template and you don't even put the title of your study in, and it's just our lawyer language, like just our procurement language, just the HIPAA language, just the regular templated language our lawyers make you use it, it's grade 11, without even saying, you're in a study with this drug or this device. So it's really, really hard. Yeah. But we do try to give them examples and do try to help, get the reading level down to something that is more readable. But I think that's why the bigger institutions use those graphic novels and these cartoons, and are able to use, different, ways, or even some of them use, I've seen sort of like a storybook to tell the story of your treatment. And, it's just not available to everyone, but we would always love to see that.
I feel like, and it's been a while since I've done this, but I feel like there was even an app created to help give descriptions of specific procedures. And it was very cartoony, storybook-like, that allowed, you could use that for certain components of the discussion with a child.
Yeah, there's one that I give to people sometimes. It's called Owl. It's Owl, and it's a cute little cartoon owl, and it's about all the different radiology scans. Because as a kid, if you were a sick kid who's going through a chronic disease like cancer or cystic fibrosis or something else where you're constantly, being seen, you're going to have imaging. And so they do these little things like, this is the CT, this is the MRI, this is the ultrasound. And they give that, so you could use that. And that's really good. I used to give that out a lot too. I think it was Owly or something like Owl something.
Yeah. And then there was also a question about compensation, how that's handled with children.
It's a really good question. So I can talk a little bit later about coercion, undue influence. And it's going to apply to children, students, employees. We can kind of talk about that as a whole. I do have some good examples where we had some, and Ken, this was through the CRC, where we had some really intense pediatric studies where a child was coming into doing 5 or 6 nights overnight in the hospital for a research study. And the monetary incentive was $2,000. And you're 10 years old. And the committee had a lot of problems with if the $2,000 was going to go to the kid or was going to go to the parent. And it was tough because They're really chronically ill kids. I forget what the disease was. They were chronically ill. And some of the committee members thought that the parents would sign their kids up because they needed a week off, and they probably did. And others were like, this is a great study, that this could really have some future benefit to the kids, and they should benefit from participating, and they're sick all the time, and they should be compensated for their time. And there was a lot of discussion around that. It took a couple meetings, and they finally came out that it was a high monetary incentive and they would allow it, and they thought it was valuable, but they wanted to make sure that it wasn't a cash value. I think they ended up doing like a government bond, something that was directly to the child. I think it was like a bond that had to go right to the kid, and the study was able to do that. So, and they still enrolled quickly and enrolled their target number, and it didn't, that's the kind of like, how can we still compensate a participant, get them in? And kids aren't driving themselves to this, right?
Right.
They're not driving themselves to the hospital. They're not checking themselves in for 7 days, and they didn't need to be checked in, right? Like they are chronically ill, but they weren't chronically ill for that week. And so how do we balance that? They're signing for themselves, but their parents in this particular case really do get to sign for them. So the committee has to say, how do we protect everybody in this situation? And those are some of the bigger committee discussions that we have to build into the protocol changes. And that was one of the big ones, was a government bond.
Yeah, great. Thank you.
Okay, so those are the three big call outs in the regulations. So subpart B, C, and D. But there are additional populations that the regs speak to, but don't have 30 pages dedicated to what we can and cannot do. So this is like students, employees, terminally ill patients, participants with substance abuse addictions, and non-English speaking participants. So we have to have, they say that the IRB must have additional protections for this group, but the IRB will have to come up with what they are. And some of them, there are specific regulations, like with non-English speaking participants and patients who don't have cognitive ability, but they don't have a specific subpart. So the first one, I'm going to talk to each one of these briefly, so you can feel free to ask a question about each one of these. So consenting non-English speakers. So this is a requirement that is pretty clear in the regulations, HHS and FDA. And unless written consent has been waived as a requirement for the study, the participants who do not speak English must be provided with a written consent document in a language understandable to them. And they must be provided an interpreter fluent in both English and the participant's spoken language to aid in the consent process. So that's pretty clear. So generally, it is a long process. And so the government calls one a long form consent process, and one the government calls one the short form consent process. And these are terms that they have come up with, long form and short form. And long form basically just means a fully translated consent form. Your identical English consent form fully translated into the participant's native tongue. So all your documents must be submitted to the IRB in English. So we review it, make sure it meets the criteria for approval, and that has all the elements of consent in it. And then once it's approved, we ask the PI to send it back to the translator. And then a modification can be submitted with the translated documents and certified that it meets the English version. A short form consent process is when your study was approved with an English only. You did not think anyone in your study was going to present as a research participant who did not speak English. So it's really for the unexpected non-English speaking participant. And there's not enough time to translate that English version of all the documents into the language the potential participant understands. So this is when you'd use the short form. And so the short form is actually, let me see if I have this on the next slide. No. So a consent document written in a language understandable to a non-English speaking individual, it's just going to have the elements of consent. So what we have here at UVM is we we have a refugee resettlement office here in Burlington. We are a big hub. And so we went to their group and we went to the hospital and said, what are your top 12 non-English speaking languages that we see here in Burlington, Vermont? And they gave us the top 12. And then what we did is you translate what they call the short form. And the short form just says, we are going to have an interpreter read to you a consent form. It's going to have the risks and the benefits of the study. It's going to have the purpose of the study. So there isn't the actual study. It is just a generic form that says someone's going to tell you the risks, the benefits, the procedures, and then you can speak to the interpreter about that. So that's only when we need to do something fast. That's usually treatment-based. We do it maybe a handful of times a year. It's like, I think the last 3 times we did it were all the same. There's a participant came into the ED really ill, and we found out they actually had a cancer. They had like leukemia or something, and we needed to treat them that day. We didn't have time to translate the 40-page leukemia document, right? So we had the interpreter come down and say, someone's going to read the document to you, and this is what it's about, why, and read it to them in their language. We can also use a short form process when we enroll a non-English speaking participant who may not have a written language such as My. And that's actually quite a few countries out of Africa. And we do see them, those countries all speak My, and they come from as part of our resettlement as well. And so we wouldn't have anything to translate, but we would be able to still have a translator come and read the document to them. Another category we see quite often is participants lacking the capacity to consent. So this is a person who has reached the legal age of consent. So they're over 18, but they lack the decision-making capacity to comprehend the consent process and voluntarily choose to participate in the research. So this is participants that may have like a traumatic brain injury. We had a study in the ED that did skateboarding injuries. So they all had TBIs. There was like we had a new skate park. We had a lot of TBIs. And so they were coming in and they really were confused. They really did not know their names. And so TBIs, dementia, stroke, substance abuse, and again, children. So this is where someone is consenting on their behalf on the consent form. So when someone consents on the behalf, the investigators must ensure the consent is still informed and voluntary and obtained with all the same appropriate safeguards. This is when you have like a surrogate consent or a legally authorized representative sign on your behalf. So illegally, and we refer to it as an LAR. So an LAR is defined in both HHS and FDA regs as an individual or judiciary or other body authorized under applicable law to consent on behalf of a potential participant to participate in procedures involved in the research. An LAR can consent on behalf of the patient for both therapeutic and non-therapeutic interventions. And so we have an example here where it shows if the participant, the protocol has to be approved for this, an LAR to sign as part of the review process. So you would say, I know I'm going to have participants in my study who may not be able to consent for themselves. And then as part of your consenting process, you would have a line on the consent form for an LAR. And so the participant would not have to sign themselves. So when you're the plan for obtaining informed consent from a surrogate or an LAR, so whenever possible, the investigators will attempt to obtain informed consent directly from the subject first. That's what we always want first, right? We want the autonomy of the subject to sign for themselves. If that's not possible, if the potential research subject is unconscious or otherwise lacking the decision-making capacity, the investigator shall document that observation in the research record. It should be very well documented as part of the research process. And then they will document who is able to provide the surrogate consent. If the potential research subject has questionable capacity to consent but is not unresponsive, the investigator will describe the research to the subject and perform and document an assessment of the participant's capacity. So we do this sometimes where we'll have quiz questions. So if it's unclear if they can consent for themselves, we may ask in the protocol, they do the consent process, they explain the study, they go over the consent form. And at the end, before they sign, we would ask them to document maybe 3 quiz questions to make sure that they understood. So do you understand, like you would quiz them and say, how many times are you going to come back into the study? Like how many times are you going to come back each week to receive study drug? Or do you know what can you tell me the total compensation? Or what is the most common risk in the study? And if they don't know those things, then they may not have the capacity, they may not understand. You may not enroll them at all if they're really confused, or you may have to do that with an LAR. But so you would assess their capacity for different, and there's different, each protocol will have a different way to assess capacity, but one of the most common ones we have is sort of like a little quiz.
Melanie, there's a question in the chat about individuals with no literacy, individuals who cannot read. Can you talk a little bit about that? Because it's a little bit different than capacity, right?
It is, yeah. So they're not, so for them, they're going to consent for themselves. Okay. And so they have the capacity to consent. They just don't have the ability to read. It's going to be in the same sort of category as like someone who has, someone who's blind, right? Or someone who's injured. They have the full capacity to, and autonomy to decide whether or not they want to participate in the research, but they need guidance around the consent documents. Someone needs to read it to them. Someone needs to, and we need to really document that process and that assistance really well. And a lot of times that requires IRB review and approval via an amendment beforehand, unless you know you're going to go out and everyone in your study that you're targeting for enrollment, you know that they're illiterate. Then you would have a really good process ahead of time but you wouldn't actually need someone to assent for or consent for them. You wouldn't need an LAR, but you would need to document that somebody read it to them and you asked them. And then that's when we would make sure that we would say, since you didn't read it yourself, what did you hear? Can you explain back to me, kind of teach back? Can you tell me? So that way we make sure that they did understand.
Right. And I mean, I think about that from an individual's inability to read, but it also could be a mechanical, like an ophthalmology study. And they, they're physically not able to read because of eye disease of some form, and thinking about that. But that would be the patient population where we would proactively put into, this is what our plan is with regard to consent. Yep.
Right. But we wouldn't say that they're vulnerable, right? Like they have the capacity and autonomy that they should be able to decide for themselves if they want to participate in the research, and someone cannot say you are, because they are lacking that ability. So I think it's like that cognitive thing that's a little bit different, but it's easy to say, well, there's lots of examples of how we had participants who came in where they had problems like the motor skills, like some of our neurology, and they were having trouble like just signing their name. They're fully capable and cognizant of what was going on, but they didn't have the ability to like sign their name or make an X. But we wouldn't have someone sign on their behalf. We would have some just document that we were able to like go over it with them, and they gave their confirmation a different way, and we would work with the IRB to document that.
Great. I think we're doing another poll question, if I'm not mistaken.
Okay.
Okay. So this is a scenario of LAR, legally authorized representative, if it's appropriate for the following research protocol.
So this is a study again that we had here. So this study this was an ED study. So the research study aimed to collect data about the levels of carbon monoxide and hemoglobin in the blood using a new medical device. So it's a new sensor that you would put on participants' fingers, and it would measure the carbon monoxide and hemoglobin in the blood. A small amount of blood would additionally be tested for carbon monoxide. And the readings from the sensor and the results of the blood test would be used to improve how the device works. So very minimal risk, but the participants were invited when they came into the ED and they showed symptoms such as headache and nausea, vomiting, dizziness or lightheadedness, fainting or loss of consciousness, shortness of breath, or other symptoms that may suggest. So they wanted to put the little device on anyone's finger in the wintertime who were showing these symptoms to see if carbon monoxide was potentially a culprit. And so, is the use of an LAR appropriate for this type of study?
Give people a few seconds to respond to the poll. Okay, I'm going to end the poll. Any last minute responders? Oops, now we got people moving. Okay, last call. I'm going to end the poll and share the results. Can everyone see the results? So Melanie, we have 60% saying yes and 40% saying no.
Oh, goodness. Okay. So you're all kind of right. So I would say we did allow an LAR for this because some of the participants were coming in unconscious. Okay. There was carbon monoxide where they were fully coming in and they were unconscious. So in that case, we did allow an LAR. If you come in and you just have a headache and you have nausea, the consent form, you would have to consent for yourself. Okay. So we allowed for the patients to consent for themselves in this, and we allowed for an LAR if they could document they were unconscious, that they did not have the ability. So in this case, we allowed for both, but they had to really document it really well. And we do our own sort of monitoring audits of the study. And if you see that an LAR was used for everyone and they walked into the ED and they walked out of the ED, they were inappropriately using an LAR. So the study also required that if the participants came in and someone signed on behalf, yes, put the finger sensor on, I want to see if it's carbon monoxide. When they woke up, the participant had to sign the consent to say, yes, you may use my data. So that data wasn't actually, even if an LAR was used for this, since they were really just collecting the data and they didn't run the tests, they ran the tests, but they said you can or cannot use my data after I wake up. So it kind of this one left. So it doesn't have to be all or nothing, right? Looking at the protocol and how the participants can come in and be eligible for different reasons, I think you can make the protocol have an LAR for some patients, and some patients they would have to consent for themselves. And okay, so our last kind of group is students and employees in research. So there's a lot of ethical considerations with this group because of the power relationship between students and their teachers. Students may feel pressured to participate in research, and similarly, because of the power relationship between a supervisor and their direct reports may feel pressured to participate in the research. And the IRB will determine if there are adequate protections to allow participants to choose to enroll in research without undue influence or coercion. And that's usually around the consent process and what we write into the consent form. So we usually require PIs to say, if you're going to your students and you want to ask them to participate, they need to understand there needs to be statements throughout that your participation is totally voluntary and your grades will not be affected if you do not participate. And the same thing with an employee. If they're asking your employee to participate, we have to make sure that it's very clear in the consent form that their participation is totally voluntary and their employment status will not be affected. So the IRB is looking to mitigate this type of risk during the review. So how can we protect the participant? So coercion, for example, the investigator might tell a prospective subject that he or she will lose access to needed health services if they do not participate in the research. So it's sort of an overt or implicit threat of harm is intentionally presented to one person or another in order to obtain their compliance. That's what we look for, the coercion. And then when we're looking for undue influences in a protocol, we want to make sure there isn't an offer or an excessive or inappropriate reward or other overture to obtain compliance. So that was sort of the undue influence when we were talking about that child's doing the overnights, the long overnight study. They were doing both, right? So in that case, we had both coercion. We were scared that the children were going to be coerced by their parents, and the undue influence was the money. So things that we try to help put into protocols when we're reviewing them, or we may suggest back to PIs when we're reviewing protocols for students and employees and children, is we may ensure that the data collected is de-identified so they don't maybe they don't know who's responding and who's not responding from their students. The recruitment is done by a person who's not teaching the class. It's not a supervisor, so they don't actually have that undue influence. We want to make sure that the consent forms are clear that their grades or their employee status will not be affected. Sometimes we ask that the research is conducted after the grades have been provided. So that way the students won't feel that their grades, even though they were told it wasn't going to be affected, they'll only participate after the grade has been given. So we can kind of still have them participate with their teacher, but now the students will feel better that it won't affect their grade. They already have their grade. And I think that's what I got. Is there any questions?
Thank you, Melanie. I've been asking questions as I've gone along, but I've opened it up to our attendees if they have any vulnerable populations that they want to ask questions about.
I just had one question. This was a long time ago, so I'm wondering if the regulations change or I'm not just not remembering it right. But I remember we had a neuro patient and there was some concerns about his cognition and but it was a study that was just looking at samples and because there was no potential benefit, an LAR was not like he was not allowed to go on the study. Is that a thing or am I misremembering?
I don't remember the exact example. I don't know exactly why. Maybe I'm not sure if the committee had maybe a collection of I don't know what the sample was. Maybe the committee was concerned about how the sample was collected, or it was.
I didn't know if it was because I thought I remember it saying if there's no benefit to someone, you can't have an LAR.
I see, Jen. I think yes, a long time ago, I believe the committee did have that.
Okay,
Yeah,
so
I
it
think
was
a long
just
time.
like,
Yeah, I think actually maybe a long time ago they did have that, and they were allowing for LARs to only consent if there was a therapeutic benefit,
okay,
and that has changed, and they're right. It was
okay.
probably a long time ago. Yeah.
I think as folks are thinking of other questions, I just sort of say thank you. You timed it so perfectly, Melanie. I don't know if you had that in your
I didn't.
mind but I just wanted to mention that the next Echo will be next year. So it's January 28th of 2026, and it will be Brianna Taylor talking about biostatistics 101. So some tests and statistics you might use in your research and study will be the next topic that we will cover. But want to be sure to get you out on time. But thank you so much. And if you have further questions, feel free to put them on the evaluation form or other ideas. There's so many different populations and things to consider for future echoes. Please include that in the evaluation and give Kim or Yvette the last word.
I just thank Melanie for being our Echo presenter today and thank everyone for participating and want to wish you a happy winter holiday season and almost a happy new year. So thank you so much for participating and we look forward to seeing you in January.
Thank
Thank
you.
you.
Okay. Bye-bye.
Thanks.